classes used as bronchodilating, or if you wish, broncholytic drug classes. Right now, we can discuss drug classes with anti-inflammatory action. So first of them is the class of anti-leukotriene drugs. Leukotrienes, I remind you again, leukotrienes are biologically active substances which are products of arachidonic cascade, arachidonic acid cascade via lipoxygenase enzyme. And actually the presence of these substances induce bronchospasm together with inflammatory mediator secretion. So today, drugs acting on leukotrienes or anti-leukotriene drugs are divided into drugs which inhibit the synthesis of leukotriene, obviously, which inhibit the enzyme transforming arachidonic acid into um, leukotrienes, so-called 5-lipoxygenase, and the drug which inhibits this synthesis is zirioton. Zirioton is present on some local pharmaceutical markets. Today it is not very popular, so you can check your local pharmaceutical market for zirioton presence. In Russia, for example, today this drug is absent. Second and more frequent subclass of anti-leukotriene drugs are antagonists for receptors for already synthesized leukotrienes. Yes, leukotriene receptor antagonists. In clinical guidelines, we can find an abbreviation LTRA, leukotriene receptor antagonists. And when well-known representatives which are present on every pharmaceutical market or all around the world are Zafir-Lucast and Montelukast. On your local pharmaceutical market, sometimes you can find another representatives from leukotriene receptor antagonists subclass. So what is the place of leukotriene receptor antagonists? Their anti-inflammatory action is moderate. So the onset of action is delayed. That is why today LTRAs are used for long-term control and prevention of symptoms in asthma. So they cannot be used as relievers, and more important, they are used in tablets. So it makes their use for relief makes this use impossible. At second, if you compare them with classical drugs, and classical drugs later we will understand, these are inhaled corticosteroids among anti-inflammatory drugs. So this comparison will not be on the side of leukotriene receptor antagonists. Steroids are more effective and are better for the prognosis. So today the place of leukotriene receptor antagonists is prevention and control of symptoms in patients who cannot tolerate inhaled corticosteroids as an alternative to inhaled corticosteroids. Or second indication, second position is add-on therapy. Additional therapy to other anti-asthmatic drugs, including corticosteroids. Yes, so we use them either to replace ICS or together with another bronchodilating and anti-inflammatory drug classes. As I've told you, the main drug class used in the treatment, as in maintenance treatment of bronchial asthma, is a class of glucocorticosteroids. The classification, in accordance to the route of administration, divides them into inhaled forms. Yes, beclometazone. Beclometazone today is not very popular because it is short-acting, and more frequently used are flunizolide, budesonide, fluticasone, and mometazone. Mometazone has appeared on pharmaceutical market within recent years, but it is also very popular to be used in pulmonology. Previously, mometazone was very popular in dermatology for the treatment of allergic disorders, in otorhinolaryngology laryngology, and in other spheres of medicine. Second kind of forms are parenteral forms of glucocorticosteroids. Obviously, parenteral forms are used for instant relief of asthmatic onsets in the most severe cases when the use of another forms is ineffective or impossible. Third kind of corticosteroids are oral forms of glucocorticosteroids, which means pills, tablets. Oral forms of corticosteroids in classifications and in clinical guidelines have an abbreviation OCS, oral corticosteroids. Inhaled corticosteroids have an abbreviation ICS. So what is the place of corticosteroids in bronchial asthma and COPD treatment, and actually why we decided they are the best in the maintenance treatment of these disorders? At first, corticosteroids have varieties of effects, and these effects directly depend on the route of administration. But even use it inhaled, they have very important actions. From one side, this is an action on inflammation. And we already discussed that actually the pathogenesis of bronchial asthma is a persistent chronic airway inflammation. At second, corticosteroids have direct action on 3 phases of allergic reaction simultaneously. That is why we discussed allergic reaction. So steroids inhibit pathoimmune, pathochemical, and pathophysiological phases of allergic reactions together. This is possible because they have direct action on eosinophils by reduction of their numbers, T lymphocytes and T helpers. They reduce the liberation of cytokines, molecules of intercellular cooperation from lymphocytes. They reduce the activity of mast cells and stabilize cellular membranes of mast cells, which actually means reduce the liberation of biological active molecules from mast cells. They can also reduce the migration of mast cells into the focus of allergic inflammation. They can reduce the activity of macrophages and their role in the pathogenesis of allergic reaction. So all of these reactions are present for corticosteroids together with positive action on structural cells, such as stabilization of epithelial cell functions, on endothelial cells. They can have direct action on smooth muscles in airways, and very important, they can directly act on mucous glands secretion, I mean on dyscrania. So let's conclude. Steroids have hormonal action, and even local hormonal action gives us benefits in their use. From another side, and this is not directly written on this picture, but this is very important for our understanding, corticosteroids have very important effect beyond anti-inflammatory or bronchodilating effect. This effect is influence on fibroblasts. In clinical studies was shown that corticosteroids can inhibit fibroblasts. Before the break, we already discussed that actually inhibition of fibroblasts is very important for the prevention of bronchial wall fibrosis. And if you wish, corticosteroids have an ability to improve the prognosis in patients with bronchial asthma because they inhibit fibroblasts and prevent bronchial wall fibrosis. So if a person has persistent inflammation in bronchial tree, if a person has high risk of bronchial wall fibrosis, the best choice is the use of corticosteroids in the prevention of these possible changes. So what are main indications for these forms? As I've told you, inhaled forms are main forms of steroid today. Yes, and these forms are used for prevention and control of asthma symptoms. The use of oral forms is already not desirable because if you use them, if you use them orally, since this moment you receive side effects related with systemic action. Yes, on next lectures, we will discuss the systemic side effects. You know all of them: Cushing syndrome, hypertension, diabetes, osteoporosis, immunosuppression, opportunistic infections, etc., etc. We can continue this list. So that is why in pulmonology is recommended to avoid oral use of steroids if possible. And of course, parenteral forms have same disadvantages. And actually today, as I've told you, we use them only for relief of severe acute asthma symptoms. Additional drug class. Additional drug class used in contemporary medicine is the class of phosphodiesterase 4th type inhibitors. So this drug class actually is a result of our search from non-specific, non-selective phosphodiesterase inhibitors. Actually, they were methylxanthines. And today we received the drug with the name roflumilast. The main effect of this drug is anti-inflammatory effect. Roflumilast today is included into clinical guidelines, has good clinical studies, I mean studies with potential benefits in daily practice use. And we need to know that main place of roflumilast use is the treatment of COPD with severe exacerbations, with frequent exacerbations in patients with a history of frequent exacerbations. The place of roflumilast in bronchial asthma is absent. So actually, we already finished the classification we discussed in the start of our lecture. Yes, so we discussed drug classes with bronchodilating effects. We discussed drug classes with anti-inflammatory effects. Yes, let's conclude. These are leukotriene receptor antagonists or another anti-leukotriene drugs. These are glucocorticosteroids. This is actually roflumilast, yes, phosphodiesterase 4 inhibitor. And additional place, and very important place today among anti-inflammatory drugs, of course, we have in the world of biologics, so-called monoclonal antibodies. Recent clinical guidelines added some drugs into the list of monoclonal antibodies used in patients with bronchial asthma. So traditionally in previous and pre-previous, if you wish, guidelines, we had only monoclonal antibodies for immunoglobulin E. Obviously, immunoglobulin E is a target of action because it starts allergic reaction in first phase. So the use of this drug class allows us to neutralize circulating immunoglobulins E in the bloodstream, and actually it will prevent symptoms of bronchial asthma and prevent exacerbations of bronchial asthma. The drug on pharmaceutical market is omalizumab. MAB means monoclonal antibody, and if you see MAB in the name of drug, you can conclude this is monoclonal antibody. Yes, so omalizumab is used subcutaneously. It is used twice a month, just 2 subcutaneous injections with a gap 2 weeks. Yes, and these injections are very effective. In some studies, the frequency of remissions was close to 70% after these injections of omalizumab. So from one side, these drugs are very effective. And we know that monoclonal antibodies are usually very effective drugs. And of course, everything has a price. And this is main disadvantage for monoclonal antibodies. Yes, in Russian Federation, in Russian rubles, omalizumab today costs approximately 15,000 of rubles for 1 month. So these 2 syringes, 2 injections cost 15,000 of rubles. But it gives very significant and prominent result. That is why these drugs are recommended to use in patients on last steps of bronchial asthma treatment, when your patient has severe allergic asthma that is uncontrolled on usual treatment. What is new? The newest guidelines give us 2 new subclasses of monoclonal antibodies acting on interleukins participating in cooperation between different immune cells. So we have anti-interleukin 5, mepolizumab, reslizumab, and benralizumab. Mepolizumab, reslizumab, and benralizumab. So all of these drugs are also used in patients with asthma uncontrolled on usual treatment. Yes, as you can see on this slide, these drugs have some limitations in the age of use. This is very important because you know that bronchial asthma is multifactorial disease with genetic predisposal, and sometimes the first onset of asthma happens in childhood. So this is very important to differentiate what drug classes are possible and impossible to use. And as you can see, in accordance to clinical studies, these drugs have some limitations. Next option, and this option is also present on pharmaceutical market, is in anti-interleukin 4, dupilumab. This drug is also used subcutaneously, is also very expensive, but is used in patients with severe asthma who already cannot respond to classical treatment and even require the maintenance use of oral corticosteroids. As I've told you, oral corticosteroids are not recommended on maintenance treatment, so it means another treatment is already ineffective. So the place of this drug is the most severe case of bronchial asthma. So we finished our conversation about main drug classes used in bronchial asthma. After that, we can already discuss general algorithms of this disease treatment. But we need to say that pharmaceutical market today also has combined forms of these drugs. Combined forms of these drugs have very significant advantage. This advantage is patients' adherence, patients' compliance, because the use of combination allows your patient to avoid additional uses, additional inhalations of drugs. Yes, obviously, being based on pathogenesis, it's better to combine one drug from anti-inflammatory classes, and golden standard is the use of ICS, and one drug from bronchodilating drugs. Yes, and classical treatment is the use of long-acting beta agonists. So today you can see different drugs combinations which are present on international market. You can check your local market in your countries for possible combinations which are present in your countries. Another form and very popular form of combination, especially in patients with COPD, is the use of two bronchodilating drugs such as long-acting beta agonists with long-acting muscarinic antagonist. Yes, and look at this list. These drugs are also present, and you can check their presence on pharmaceutical market in your own country. So why these combinations are so important? These combinations are not just mechanical combinations. So the most important combination, and later I will explain you an example of pathogenetic treatment of bronchial asthma. This combination, such as inhaled corticosteroid with LABA, has double action, and the factors of this interaction allows to improve the efficacy of treatment. This is so-called potensive action or synergy, which allows to minimize the dose of drugs taken, but to maximize the chance to receive remissions and to reduce the risk of side effects occurrence. So, being based on this information, we already can describe and discuss general algorithm of bronchial asthma treatment. We receive enough information to decide what treatment to use and what treatment is the best. On this picture, you can see a general algorithm of bronchial asthma treatment in accordance to recent clinical guidelines for bronchial asthma, GINA 2021. As you can see, today clinical guidelines and experts in the asthma treatment give us two main variants, so-called tracks for treatment. Yes, track number 1 and track number 2. Track number 1 is called controller and preferred reliever. Track number 2 is called controller and alternative reliever. I'll be honest with you, before the introduction of these clinical guidelines, the classical treatment was treatment which corresponds to track number 2. And in previous departments, if you wish, previous teachers explained you the treatment of bronchial asthma in accordance to this track. It was the main. So that is why today I will start my explanation with this track, because actually you already know this track. And after that, I will explain you main changes which are made in track number 1, and I will explain you why we decided to assume this track number 1 as the main and preferable today. So track number 2, classical track, if you wish, historical track, contains two main drugs and two main combinations sometimes. Yes, so first drug we already discussed is a reliever. So the drug which is used for relief of acute onsets of bronchial asthma. What is this reliever? Obviously, this should be SEBA, short-acting beta agonist. As I've told you, another drugs, even with a short action, from antimuscarinic drugs, for example, this is ipratropium bromide, deliver their effect later, 15, 20, 30, 40 minutes later after intake, which makes their use for relief impossible. So the main option is the use of SEBA, short-acting beta agonists. You are welcome. You can use salbutamol, you can use phenytoin, terbutaline. This is on your choice. And you already understood that this same reliever is used on any step of bronchial asthma treatment, and it doesn't depend on step. So we invented nothing else. Yes. What about controller? I remind you again, the reliever is a drug used to relieve asthmatic onsets. Yes, while controller is a drug used for prevent the risk of exacerbations and to prevent symptoms of bronchial asthma. So it is used for the prevention. So the intensity of controller treatment, these controllers are written on this step. The intensity of controller treatment directly depends on steps of bronchial asthma. Today, these steps don't have their names, but frankly speaking, in previous revisions of guidelines, all of these steps had their names, which explain the severity of asthma and possibilities of our treatment, which explained the aggression we should apply to treat these steps. Today, these steps don't have any names because experts underline the presence of steps names sometimes disappoint doctors. So doctors seeing the name of step decide these changes are irreversible. And if a person has step number 3, for example, he will never have a step number 2. But this is incorrect. I've already told you, and this is written in definition of bronchial asthma. Yes, these changes are particularly reversible. And actually, we can act on these changes. We can make the control of bronchial asthma. And later, I will explain you how to make this control. So let's take a look. Step number 1. Step number 1 is present in patients with rare symptoms and even very rare symptoms of bronchial asthma. These symptoms occur less than twice a month. Less than twice a month. So these symptoms are unusual for patients, and in daily practice, maybe sometimes they don't have these symptoms during months and months in order. So what does it mean? It means that allergic inflammation or another kind of aseptical inflammation in bronchial tree is not persistent. It is intermittent, and it means the low risk of bronchial wall fibrosis. If inflammation is intermittent, it means that fibroblasts are not very active in this bronchial tree, and it means the risk of bronchial wall fibrosis occurrence and progression is low. That is why maintenance treatment on these steps maybe sometimes is even not recommended. So on step number 1, you can understand it by color of this rectangle. Yes, so step number 1, you can sometimes take ICS whenever SEBA is taken, but maintenance keyword is absent for this step. And sometimes clinical guidelines even recommend to avoid any controller on this step since inflammation is not persistent. Step number 2. On step number 2, the inflammation becomes persistent. This is moderate, it is light, yes, but it is always present with your patient. Clinically, this inflammation corresponds to symptoms which occur twice a month or more, but still less than 4 or 5 days a week. If a person has persistent inflammation of bronchial tree, what should we do? we should use anti-inflammatory drugs. What anti-inflammatory drugs are drugs of choice? Obviously, drugs with potential influence on the prognosis. How to act on the prognosis? To act on the prognosis, we should use drugs which can inhibit fibroblasts, because fibroblasts excessive activation is the reason of negative prognosis in these patients. What is our choice? Our choice is the use of corticosteroids. And look at this, maintenance corticosteroids. Next message from this step, inhaled corticosteroids. As I told you, the best choice is the use of inhaled corticosteroids. Inhaled use of corticosteroids allows us to avoid side effects related with systemic steroids action. The bioavailability of steroids in inhaled route of administration is not very high. So they stay in bronchi and have local action in bronchi. Do not forget that doses of steroids you use in inhaled form are measured in micrograms instead of milligrams used orally. So this is 1,000 times lower dose, and it minimizes the risk of steroids related side effects too. Do not forget that if you use them orally, you will need to change the dose in accordance to activity of liver enzymes, so-called liver pass effect. So all of these disadvantages make the use of oral route of administration impossible in daily use of bronchial asthma anti-asthmatic drugs. So for me, this is significant and huge mistake when your patient takes oral corticosteroid instead of inhaled on earlier steps of bronchial asthma treatment. Why am I so emotional? Because unfortunately, it happens. It happens because sometimes patients take oral corticosteroids, and we can explain why. Because this is very cheap. Inhaled corticosteroid can cost 1-2,000 of rubles for every month, while oral corticosteroids are absolutely cheap. So your patient can spend 20-30 rubles and to receive a package for a month. But the price of these actually is systemic action and the presence of side effects. So let's conclude. On step number 2, we should already administer maintenance treatment, so daily treatment, and the choice of this treatment is inhaled corticosteroids. For step number 2, when the inflammation is persistent but moderate, light if you wish, low dose of inhaled corticosteroid is enough. So the step number 2 is usually treated by low doses maintenance inhaled corticosteroid. Next steps actually have absolutely same principle, but the difference is just very simple. On step number 3, so this is medium severe asthma, when your patient has symptoms the most of days, or sometimes he is even awakened with asthma once a week or more at night. Yes, in this case, we can use two approaches, two decisions. First decision, we can increase the dose of steroid alone. Yes, why not? If your patient had low dose of steroid on step number 2, why not to increase the dose of steroid on step number 3? Another option is to combine still low dose of ICS, but with another drug. In this case, obviously, with bronchodilating drugs such as long-acting beta agonists, especially if we have combinations present on pharmaceutical market inside one single inhaler. So what option is better? What is better, to use one single drug, I mean steroid in medium dose, or to use the combination? Obviously, and it is written on this picture, it is better to use low dose of inhaled steroid, but with in combination with LABA. What are advantages of this approach? First advantage is efficacy. Everybody knows that combination, synergy and potency action always can give us better results than the use of monotherapy alone. And this principle works in pulmonology as well. So in clinical studies was shown that the combination is always more effective than the increasement of steroid dose alone. Second thing, we need not to forget that on next steps of bronchial asthma treatment, we will increase the dose of steroids. We will have to do that. Yes, look at these medium doses of steroids, high doses of steroids. So if you spend these doses today, what will you do tomorrow? So that is why today is better to combine steroid than to administer higher doses of steroids. This is so-called steroid saving strategy. It allows us to save the dose of steroid, effective dose of steroid for patients' future. So that is why today step 3 is recommended to lead using low dose maintenance of inhaled corticosteroid together with LEPA. The use of medium dose of steroids is recommended when your patient cannot tolerate LEPA, for example. Step number 4. Step number 4 is for patients with severe asthma. Daily symptoms, waking with asthma once a week or more, long lung function. What to do with these patients? In this case, we have to increase the dose of inhaler, and usually we increase both the dose of ICS and the dose of LEPA. So we should administer an inhaler with increased doses for this patient. It will allow to receive adequate control of symptoms. Already on this step, you can consider the use of another combinations in accordance to patient's phenotype. So you can try to combine the ICS, for example, with LEMA or with another drug class in accordance to your opinion and your behavior towards this certain individual patient. Step number 5. In previous guidelines, this step was called most severe bronchial asthma. On this step, actually, we should consider aggressive treatment of bronchial asthma. What can we do? At first, we can use triple combination. So let's take a look at on LEMA. So we will receive ICS, LEBA, and LEMA together. 3 drugs together. Next option is the use of high doses of double combination. Yes, high dose of ICS and LEBA. Another option is the use of so-called phenotypic assessment. So in clinical guidelines, if you will be interested in it, you will find how to make this phenotypic assessment. So persons with different phenotypes can receive drugs in accordance to their phenotype, in accordance to their clinical picture, and this phenotypic assessment can give additional results. And at last, a very important option, we can add monoclonal antibodies. Yes, anti-IgE, anti-interleukin-5 or 4. But do not forget about the price of this treatment. Yes, this treatment is very effective. It is rational in accordance to cost-effectiveness ratio on step number 5. But of course, in daily practice, actually, usually patients take this treatment if insurance medicine actually pays for that because this treatment is expensive. The last option written on this page, and this is also for step number 5, is the use of short course oral corticosteroids. So we are trying to administer systemic oral corticosteroids. The idea of systemic corticosteroids use is very simple. We are trying to switch off the immune system. So we are trying to cause immunosuppression. Obviously, this is very bad decision, and today the use of oral corticosteroids shows that actually the treatment is ineffective. That is why it is very important to prevent the development of later steps of bronchial asthma, and early prevention of these steps allows these patients to avoid step number 5. Just few words in the conclusion about bronchial asthma, and just couple of words about the treatment of COPD. We need to know that today, as I've already told you, these steps of bronchial asthma treatment are not forever. So today, the treatment of asthma is a dynamic process. And look at this, clinical guidelines recommend us to use so-called asthma management cycle for personalized asthma care. The idea of this cycle is very simple. after initial diagnosis and treatment, yes, 3 months later, you already can make a conclusion about the efficacy of treatment. So you can assess this treatment. If this treatment is effective, for example, you decided to lead your patient on step number 3, and if this treatment is effective, you can continue this treatment. If this treatment is ineffective, you should adjust this treatment. Yes, and this adjustment can be both increasement and decreasement. If your patient was stable in symptoms, you can even try to reduce the aggression of your treatment, for example, into step number 2. If symptoms are progressing and your treatment is ineffective, you can review this treatment and to adjust this treatment into higher step of treatment. So the main conclusion about bronchial asthma treatment is control of your patient. It doesn't mean you indicate him treatment and forget about him forever. You need to reassess his condition. And today, bronchial asthma guidelines contain a questionnaire which allows us to make this differentiated choice of treatment and adjustment of treatment. Just a couple of words in conclusion about COPD. So we already discussed main anti-inflammatory and bronchodilating drug classes used in asthma, and actually absolutely same drug classes are used in COPD treatment too. So what is the difference? The difference is in the pathogenesis. In bronchial asthma, main pathogenetic variant is allergic reaction, while in COPD, the main pathogenesis is a bronchial wall change in accordance to irritants and pollutants inhalation. Since we have another pathogenesis, the treatment can be slightly different too. So you can see initial pharmacological treatment recommended by so-called GOLD guidelines. GOLD guidelines are global initiative for obstructive lungs disease. This is a 22nd year's revision of guidelines, so this is a recent document. How to make the choice of bronchodilating treatment in these patients? Actually, guidelines recommend us to divide patients into 4 groups, A, B, C, D. How to divide them? Two things we need to know. First, frequency of exacerbations. So patients with rare exacerbations and not serious exacerbations belong to groups A or B. Patients with severe and frequent exacerbations belong to groups C and D. So if a person has low frequency of exacerbations, we need to assess the frequency of dyspnea symptoms. And these abbreviations are just questionnaires which allow to assess the frequency of symptoms. If you are interested in it, you can open clinical guidelines and to find this information. So if symptoms are rare, your patient belongs to group A. If symptoms are frequent, your patient belongs to group B. Yes, absolutely same for patients with a severe and moderate exacerbations. Yes, if symptoms of dyspnea are rare, your group is C. If symptoms are frequent, your patient's group is D. So in accordance to that, clinical guidelines recommend to use different inhalers. For group A, any bronchodilator works, so this is on your choice. For group B, it's better to use long-acting bronchodilators such as LEBA or LEMA. But again, this is on your choice again. For group C, the drugs of choice are LEMA, so long-acting muscarinic antagonists. For group D, actually, you can see that you should consider the use of inhaled corticosteroids or drugs combinations. So this group is most severe because it has frequent exacerbations and frequent dyspnea symptoms. After that, clinical guidelines recommend us to reassess and adjust the treatment, and again, it depends on symptoms. If dyspnea is frequent, you can combine LEBA or LEMA with inhaled corticosteroids. If exacerbations are frequent, you should add anti-inflammatory drug. I mean roflumilast. We already discussed the place of this drug in this treatment. You should consider the use of inhaled corticosteroids, but please be careful because the use of steroids in these patients can be related with pneumonia because these exacerbations can be bacterial. Yes, and at last, in some selected patients, you can see we can use even azithromycin, so antibacterial treatment. So let's conclude. The treatment of bronchial asthma and COPD is very close, and main difference actually is in the pathogenesis. That is why the place of lemma is more important in COPD. The place of LEBA and glucocorticosteroids is more important in bronchial asthma. The main conclusion and main consideration about this topic today, colleagues. I can recall a case of real patient. She was delivered into our hospital with end stage of bronchial asthma and heart failure. And she unfortunately died after this exacerbation of bronchial asthma. Before her death, we had a conversation with this patient about her treatment and her assumptions about inefficacy of this treatment. She was 45 years old lady, please pay attention, and she died. And she explained before her death, she decided never to take inhaled corticosteroids because she afraid of their side effects. Do not forget, inhaled corticosteroids are maintenance treatment of bronchial asthma today, and inhaled corticosteroids are usually safe. So this treatment is prognosis modifying treatment. And this is my message for you. Of course, I understand not all of you will become pulmonologists or clinical pharmacologists, but even you become surgeons, gynecologists, ophthalmologists, or somebody else. If you will see the picture of uncontrolled bronchial asthma, just check if your patient takes steroids. Just check if your patient takes long-acting beta agonists. Just check if your patient takes non-recommended drugs such as methylxanthine tablets or oral corticosteroids. And if you have any doubts, if you have any controversies, please send this patient to visit pulmonologist. It can save his life. Thank you for your attention. This is enough for today. If you've got any questions, you can ask me or you can write into the chat. You are welcome. Colleagues, have you got any questions?
No, sir.
Oh, okay. If you don't have any questions, thank you very much. See you on next lecture. Have a nice day. Have a good mood. Bye-bye.
Sir, до свидания.
Thank you, sir.
Thank
До
you, sir.
свидания.
Thank you, sir. До свидания.